doctors. I'm Dr. Chris Rapoff of DC QME Continuing Education, and welcome to this week's presentation. Today we tackle a topic that has major implications not only in the world of workers' compensation, but in the general population as well. This has to deal with basic pain mechanism and the control of pain. This information is taken from the textbook of Musculoskeletal Disorders in the Workplace, and this chapter is authored by James N. Weinstein. Now today we're going to focus primarily on low back pain, a condition that we as QMEs are confronted with in many of our QME examinations. Today is the first installment of a two-part series on the mechanism of pain, specifically lower back pain. We'll discuss the following sources of lower back pain. They would include the intervertebral disc, facet joints, muscles, and lumbar nerve roots. So let's get started. Despite the magnitude of the problem of lower back pain, its causes remain largely obscure. In the last 50 years, much of the focus has been on ruptured or herniated intervertebral discs. Other suspected sources of low back pain include the nerve roots, the lumbar facet joints, paraspinal muscles, and the posterior longitudinal ligament. The occupational factors contributing to the prevalence of low back pain are difficult to research because of the uncertainty of the cause and exposure. Healthy workers are more difficult to assess than unhealthy workers, and injury mechanisms remain unclear. So disability may be related to work factors, individual factors, and medical, legal, and social factors. Known work factors including heavy lifting, static work postures, bending and twisting, and exposure to vibration are all associated with increased risk of back pain. Psychosocial and psychological factors in the workplace include dissatisfaction with work as an important risk factor in lower back pain disability. Gender appears to be of little importance with respect to low back symptoms, although women seem to have an increased prevalence after menopause. Now, according to the Arthritis Foundation, 40% of all visits to neurosurgeons and orthopedists are for complaints of low back pain. It's estimated that more than 70% of the population experiences low back pain at some time during their adulthood. By inference, the longer one lives, the greater one's chances of the development of low back pain are. So despite the frequency of this complaint, back pain is notoriously difficult to diagnose and treat, partly because of the complex structures of the spine. Only 10 to 15% of the patients with back pain complaints have a known cause. Symptoms don't always correspond to the severity of the disorder as well. Relatively minor, self-limiting injuries can produce incapacitating pain, whereas extensive pathology may initially cause mild symptoms. The one thing that we can state with confidence is that the clinical manifestations of lower back pain do not necessarily reflect the cause or severity of the disease. So just what are the sources involved in the generation of low back pain in, for instance, sciatica? Well, over the past decade, Kuslik et al., some researchers reported nearly 200 consecutive patients that they studied prospectively. The authors used regional anesthesia in 193 consecutive patients undergoing decompression for a herniated disc or lumbar spine stenosis. Interestingly, when touched or even cut, the lumbar fascia was anesthetic. The supraspinous ligament produced some level of back pain, but the nerves never produced pain in response to general pressure. Now, on the other hand, when the base of the muscles was touched, especially at the site of the blood vessels or the nerves at the attachment to the bone, localized low back pain often resulted. So it's hypothesized that the pain is mostly derived from local vessels and nerves rather than just the muscle bundles themselves. A normal nerve root is generally insensitive to pain, but with retraction over a long period of time, mild paresthesias did result, but did not cause a significant pain. Now, stimulation of the compressed or a stretched nerve root consistently produced pain in the same sciatic distribution that the patient had before the cervical intervention. So it appears that sciatica is only reproduced when a previously stretched, compressed, or swollen nerve root is stimulated. In the case of a stretched, compressed, or swollen nerve root, sciatica was reproduced with either pressure or stretch of the caudal dura, the nerve root sleeve, the ganglion, or the nerve distal to the ganglion. In Kuchlick's population of patients, 2/3 experienced similar preoperative pain when the outer part of the annulus was stimulated. Buttock pain was only produced by simultaneous stimulation or pressure on the nerve root and the outer surface of the annulus. Both of them. Now, referred pain is pretty interesting. That it's clear from the research that the central part of the annulus and the posterior longitudinal ligament produce central back pain. Stimulation to the right or the left of central of the posterior longitudinal ligament was associated with pain on the side of the stimulus. The vertebral end plates appear to be pressure sensitive, and curettage results in a deep rather than superficial low back pain. So in many cases, the pain is more severe than the preoperative pain. The facet joints did produce sharp and localized pain in the region of dissection. Interestingly, the findings around the facet joints were inconsistent, and the pain often perceived as deep and dull. In the case of the facet joints, intra-articular injections were not necessary for relieving the pain, but periarticular injections always blocked the pain around the facet joint. The ligamentum flavum, epidural fat, nucleus pulposus, and the bony lamina, posterior dura, and spinous processes caused pain during the mechanical stimulation as well. Now let's talk about the intervertebral disc and the nerve roots. Hirsch et al. Reported that a hypertonic saline injected into the disc produces severe pain, which would be identical to real lumbago. And it couldn't be localized, but was described as a deep aching across the back. Another researcher, in a review of the current literature, concluded that the disc may be the primary source of the production of low back pain. However, the mechanisms of pain production still remain uncertain, even with the intervertebral disc and nerve roots. Now on to facet joints. So the facet joint capsules are richly innervated and can undergo extensive stretch during physiologic loading. So whether the facet joint pain is due to capsular deformation, bony impingement, or a combination thereof remains unanswered. Injections of hypertonic solution into the facet joint capsules, the researchers were able to produce the typical low back symptoms. This included the radiation of pain into the posterior of the thigh. Similar studies reported by other researchers also suggest that the facet joint pathology plays a large role in low back pain. Now, a literature review of the facet block success rates and facet rhizolysis was also performed. And here they demonstrated a 50 to 60% success rate. A definitive set of diagnostic criteria regarding what part the facet syndrome plays in the mixed success rates of these treatment modalities is really needed. Now, recently, another researcher found that no statistical difference in the treatment outcomes of those who received facet injections with a corticosteroid and an analgesic as compared to those injected with just saline. We've already touched on this briefly, but let's discuss it again, and it's muscular pain. The most common diagnosis for low back pain is an acute sprain or strain. We see this all the time in our QME examinees. However, the scientific evidence for low back pain of muscle origin is lacking. And some patients are known to have palpable findings in their back muscles during a physical exam with associated increased myoelectric activity, where the others have suggested no increased activity. So it is pretty uncertain as to muscular pain causing low back pain. Moving on to lumbar nerve roots, researchers actually placed nylon threads in various lumbar tissue sites during operations of the spine. Now, these threads exited the surgical wound and were pulled upon in the postoperative period to determine pain and sensitivity in the affected spinal tissues. Pretty interesting concept. Now, the most common pain site was the annulus fibrosus. Nerve roots compressed by discs or bony impingement were thought to be the cause of sciatica and were painful and sensitive. Normal or uninvolved nerve roots were not associated with pain at all. Now, Greenberg et al., another researcher, also reported that compressed and inflamed nerve roots were very sensitive to mechanical manipulation. Now, as previously pointed out, Kuslik demonstrated that the stimulation of stretched, compressed, or swollen nerve roots causes significant pain in 90% of the patients, and the nerve root was the only tissue site that upon stimulation reproduced the patient's sciatica. Now, in fewer than 10% of the cases, the uninvolved nerve roots and normal nerves were then stimulated, and they produced significant pain, but only 10% of those. Now, in summary today, this part one of our two-part series, we began our discussion on the causes of lower back pain, and we touched on several of the possible causes of pain. But as you can see, there's not a real finite list of causes for this debilitating condition. In fact, even the latest research leaves us with more questions than answers on the cause of lower back pain. This time we touched on the more popular causes, such as disc, facet joints, muscles, and lumbar nerve roots. Now, next time, we're going to explore the fascinating topic as we discuss the neurophysiology and the chemical mediators of nociception, neurogenic mediators, and how they play a role in the production of lower back pain. So, doctors, again, I'm Dr. Chris Rapoff, and wanted to thank you for taking the time to join me in today's presentation. I hope you enjoyed this first installment, and I hope you join me next time as I conclude this short series on basic pain mechanism and its control. So until then, thank you for listening.